Hi, good afternoon, everyone. It's just gone 4 on the hour, and I see we are rapidly exceeding our critical mass in terms of attendees. So I'm going to start this afternoon's meeting. My name is Mark Hendricks. I'm a pediatric oncologist from Red Cross War Memorial Children's Hospital in Cape Town, and I'm going to take you through a few housekeeping things before I introduce you to our speaker for this afternoon. So today's deep dive, as you know, is presented by Blood SA in collaboration with Aspen. And just to remind you that these sessions are recorded and the URL is visible there for you to find post hoc if you need to under the label resources and then deep dive. Please, as the comment box suggests, feel free to add questions or comments during the course of the meeting. I'll try and keep track of those. As we get Andrew to address some of your questions. In terms of your CPD points, for those of you who need those, they are available for those who are registered South African attendees. And please be sure that you enter your number correctly if you want those points to be sent back to you in the correct fashion. And also importantly, you need to be an attendant in this meeting for at least an hour in order to earn those CPD points. There is a QR code available for you if you want to be added to the mailing list. And I'm sure you all know how to use that. And again, the organizers welcome any feedback that you may have that you can make via that portal. These are the important people who manage the space. And so just to recognize them, Estelle Verberg, Gerdien Kritzinger, and Nicole Smith in their various portfolios. And then just to remind you that next week we will be taking a buy so that to allow for our Muslim colleagues to celebrate Eid next week as they come to the end of the holy month of Ramadan. I will let Andrew talk about his own topic, but this particular topic is of particular interest to pediatric practitioners, which is why I was asked to chair. And so I'm interested to see what Andrew has to say this afternoon. I see many of my pediatric colleagues have already joined and are in the room. And so it will follow the usual format. Andrew will give us a presentation. What will follow will be some questions and answers and discussions, and then we will close the afternoon thereafter. And then just by way of brief introduction, Andrew is very well known to many of you who has been a clinical hematologist since 2001, and he was our very esteemed colleague here in Cape Town for many years and has taught me a lot about transplant and other issues in hematology, for which I remain very grateful. He then since left to join the clinical team in the private sector at Pretoria, where he's currently working at Albert Cellular Therapy. And of course, he is one of the people in the country to whom we can always go to advice related to transplantation and also hematology research in which he is actively engaged. So welcome to Andrew, and thank you for taking the time to speak to us this afternoon, and we look forward to a fascinating talk and then some questions and discussions thereafter. Thank you so much.
Thank you, Mark. You are aware that I'm going to defer all pediatric questions to you. Okay, so ALL in 2025. So I'm very aware. I wanted to catch your title, but I'm very aware that sort of late millennials and Gen Zs are not going to get this at all. But ask your older colleagues, particularly those who are a bit more fabulous. You might get the appropriate answer. Just to say, this is a disclaimer from Aspen, who is sponsoring this talk, and just my disclosures in the ALL space. So we obviously know we have been significantly improving the outcomes in ALL. This is taken from obviously the US data from the SEER database. And this is really per decade. So you can see the sort of the orangey colors, or pink color, coming out from the 1980s and then the subsequent decades that follow. And obviously we can see that especially our pediatric colleagues, especially in the sort of, let's put it in inverted commas, good, but officially standard risk in young children have really good outcomes, and they have been working hard at improving those outcomes. Obviously, as we get older, those outcomes have been dipping. We're not going to get into the controversy about who is best to treat young adults and teenagers and that controversy. But to say that obviously as we get older, the results are dipping off. But we, at least for the sort of middle age, we have improved outcomes as we kind of have moved to more intensive pediatric inspired regimens. After about the age of 40, between age and 40, 50, the use of asparaginase becomes particularly problematic in terms of outcomes, in terms of complications, especially thrombotic complications. We've seen a couple of mesenteric venous obstructions and essentially bowel infarctions and death from asparaginase in the older population. So we really have been struggling to improve outcomes. So kind of made the comment in pediatrics, we just need to put the cherry on top of the cake. We're doing very well. We are still learning how to bake that cake in adult ALL. So this is a talk about specifically about bispecifics. So I'm going to take a detour along the way, but obviously this is a gift from abfab. So what we really want is to have that champagne filled sort of immediately, so that we have an ample supply of. We didn't just go to the fridge, the chemo fridge in this case, not the champagne fridge, and get the drug out. But Patsy and Eddie's favorite tipple is Bollinger, or Bolly as they call it, and particularly the more expensive versions. And I've just looked at some prices in South Africa. I mean, I don't know if any of you have paid 3,500 Rand for a bottle of this. Is readily available in South Africa. I don't know that I have paid anywhere near that value for a bottle of champagne. So yeah, really that's kind of where we're going in terms of the talk, that we'd like to have it, but cost is a major issue. I'm going to detour before we get to ALL though, because and I've shown some of these slides before, but there's also some new stuff that we need to discuss going forward, because it's going to impact drug names. So just monoclonal antibody history. So you can see, obviously, it's actually quite a long history, but really the first monoclonals that we used, actually, interestingly, Campath comes up there. And I'm using Campath here as its generic formulation, because both 1M and then the IgG formulation 1G were never actually marketed. Alemtuzumab was marketed as Mab-Campath. So that's obviously a humanized antibody. So you can tell also from the suffix sort of what generally the structure of this antibody is. So rituximab would come under obviously the chimeric antibodies. Very few murine antibodies left. And something like alemtuzumab would be humanized, and then the UMAB as well would be fully human. However, there have been a lot of problems with this. So this is the INN is the global system for naming drugs in terms of at least the pharmaceutical component, or the generic inverted commas component. Obviously, each country, and based on discussion with a pharmaceutical company, will have a different trade name, or may have a different trade name for a drug. But there have been lots of problems, but there's actually really no no definition of what actually makes a human versus humanized. And they kind of use a sort of arbitrary threshold of 85%. But I mean, really, I mean, there's a long slide and lots of waffle. But it's really a big problem in terms of naming these drugs. They're really just we're probably nearing 1,000 monoclonal antibodies now, and really it's becoming a major issue in terms of naming. So in 2021 going into 2022, there's actually a new naming nomenclature for monoclonal antibodies. So really, this is going forward, so this won't be retrospective. So you don't have to learn new names for your for older drugs. But going forward, this is going to be the naming structure of monoclonals, or bispecifics, as it may be. There's going to be a prefix, which is obviously going to be decided by the drug company. So that's in discussion with INN. There'll be an infix. Most of our monoclonals that we're probably going to be using in oncology and hematology are going to have the TAR infix. But I've just thought probably we're going to may see immunosuppressive, immunostimulatory, and growth factors coming up there as well. Maybe also amyloid. And then the suffix, remember that if you're going back to this one, the suffix kind of gave an indication of what the drug was. That is kept, but except the suffixes are going to all change. In fact, we're busy with a trial with a bispecific BCMA antibody for myeloma that until recently just had a number, but now is going to be called etentamig. So MIG for the bispecifics, TAR for the tumor, and ETEN for what the company has chosen. So essentially, you can see that you're going to need to learn a whole new naming structure for antibodies. Good luck to us old people. The young people are going to remember this, but we're going to struggle. We're going to still be going Mabs for a very long time. Just very quickly, improvements to monoclonals. You're already aware of these at subcut, and that is also happening in the blinatumomab discussion as well. Longer acting FC enhancement. So something like tafasitamab, but that's in lymphoma, has been increased ADCC, but obviously the other alternative in bispecifics where you're trying to get rid of CRS, etc., you can actually downscale FC interaction. So there are a whole lot of things that have been used. I'm not going to, this is really relevant for the discussion today. What is relevant is obviously just this is ADCs. So just a kind of list of ADCs that are out there that are really being looked at, particularly in adults, but also in pediatric use as well. Obviously, AML, gemtuzumab went and came back. Brentuximab in the Hodgkin space, so the anti-CD30, and then inotuzumab for ALL. So you can always see that they have different sort of bases, and the payload is the toxic, too toxic for systemic use and needs to be directed. And it's really the payload that actually determines the toxicity. So calicheamycin, which is obviously in GO and IO, is essentially prone to sinusoidal obstruction syndrome or veno-occlusive disease of the liver. MMAE in Polar and Brentux is particularly neurotoxic. Belantamab, MAF, particularly keratotoxic. And the first word's going to still have the monoclonal, and that's going to conform to the new naming system when new ADCs come out. And the second load is pretty much going to say the same. It's really the payload, the toxin, or sort of chemotherapy. And then very quickly, just to get it off, the concept of biospecifics has been around for a very long time, going back to the 60s. I'm not going to go through blow by blow, but obviously, as we've hit the late 2000s, we've now that promise has been realized, and we now have biospecifics in clinical use. Just in terms of biospecific structure, they're all different. Just to say, most of the biospecifics out there are IgG-like, and each company really kind of has got a proprietary platform, which is going to make it really difficult to make biosimilars in this space, because they've all kind of licensed platforms. But most of them are IgG-like, obviously have longer half-lives, and can be given sort of longer intervals. Non-IgG, I know we've still got a full immunoglobulin here, is really got quite short half-lives, but less immunogenicity, and but then they need obviously to be given as continuous infusion. So he has blinatumomab, he has the BITE structure. So just to make it clear, and I'm including myself into this, until a couple of years ago, I was also making this mistake. BITEs are bispecific, but not all they're not interchangeable. You can't call a bispecific a BITE. A BITE is a very specific structure, and referring to that. Whereas when most of us are talking about bispecific antibodies, we're really looking at something that is more an IgG-like structure. So I made that mistake at one ASH, walking up to a colleague and asking him what it's to explain something about the BITEs, and he said, no, this is not a BITE. This is a bispecific different structure. So it's sort of hard to have a pie thrown in your face. And then obviously the action, that's really the antibody is the linker that brings in T cells non-specifically to whatever tumor you were looking at, either CD19 or 20, obviously in B cells, and then really allows for tumor kill. And then most of them are really bringing in T cells, although there are some some 16 NK based or CD47, so the macrophage activations, but obviously most of them are really going to be CD3 or T cell engagers. Immune checkpoint blocking is also predominantly in solid organs, and then there are a whole lot of other sort of mechanisms of action of biospecifics as well. Okay, so let's, even though I haven't just said biospecifics, which is where we are mainly headed in this talk, let's just go back a step and look at rituximab. So between 30 to 50% of B-ALLs, and not including Burkitt's, yeah, we're talking precursor B ALL do actually express CD20, and it has been kind of said the arbitrary definition of having more than 20% of cells expressing CD20 would be classified as positive. And there is some data for increase in CD20 expression through induction chemotherapy. MRD positive blasts at the end of induction do have higher levels, and there's some more lab work looking at steroids increasing expression of CD20. So really kind of rationale for bringing in rituximab. I'm not going to go blow by blow. I'm sorry that there's too much to go through, but just look at the two major randomized trials in adults that looked at this. And this was the GRAL 2005, and the R was a subset of the whole GRAL 2005 trial, where they took Philadelphia negative BLLs, and for those people who had CD20 of more than 20% expression on cells, were randomized to receive rituximab or the standard control protocol. The important thing about this one is that they used considerable a number of doses, and that was really throughout the induction, intensification, and subsequent phases of therapy. And you can see there is actually a significant difference between outcomes. You can just see it just scrapes in if you look at the sort of overall improvement giving rituximab just scrapes into significance, but certainly better event-free survival, reduced relapse, and better overall survival. So in this study, adding rituximab to CD20 positive was helpful. The UK ALL 14, she took patients who are, again, pretty much the same population, but in this setting, randomized them irrespective of CD20. So it doesn't really matter what your CD20 was like, you were randomized to getting rituximab or not. However, the big difference in this study is they only use 4 doses and only use those 4 doses in induction. And so really the outcomes are not there. There's maybe a trend to better survival with event-free survival with the addition of rituximab, but it didn't reach clinical significance. Possibly better in the more elderly. Female, we know that men have higher clearance rates of rituximab. So maybe the dosing is an issue. Maybe you didn't need more, or maybe that's an indication of that. Lower white cell cancer, again, maybe you needed more drug to really combat the disease, and obviously absent of high risk genetics. But there wasn't actually, interestingly, any trend in terms of CD20 or the intensity of CD20 expression. So what are we doing? I mean, if we get a CD20 positive, we are still actually adding Ritux, and essentially trying to give at least through induction plus intensification phases of our protocol. So we are definitely following, I mean, giving the rituximab and hoping for better outcomes. I don't think we have enough patients to really look at outcomes in terms of in a statistical fashion. Okay, moving on to blinatumomab, which is kind of where Aspen, which is really taken over the marketing of Amgen products in South Africa, is involved in. So just starting off in adults, and there's in relapse refractory. So a couple of trials here. There is also data, and we're not going to get through everything for blinatumomab, but there is data in Philadelphia positive ALL as well, and then also in the pediatric setting, which we'll just show a couple of slides from that as well. So this is the adult setting. This is the Tower study, and they randomized adults in first or subsequent relapses to receiving standard of care chemotherapy versus blinatumomab. So overall, the overall study on an intent to treat, you essentially gained a couple of months, so probably about 3 months overall survival. But you can see towards the end, later down the line, those overall survival probabilities merged again. So really what they're saying is that if you've got a patient, an adult who's relapsed, and you have got a transplant option, this is certainly a very useful addition to therapy. But if you haven't got that transplant option, they're either too frail, or there's problems, or you haven't got a donor, you're probably using a very expensive drug for a couple of months longer lifespan. If you did it early, so this is just pulling out the people who got it in first relapse, so obviously first salvage, they did do better than the overall group. I mean, that's in any drug in oncology, we can show that, you know, the earlier you bring in the line, the better they'll do. So the question is, obviously, you've got a donor, consider it. The question is, if you didn't, why didn't you transplant an adult in first CR? It remains the big question, and allowing them to relapse is a bit of an issue. Pediatrics. So this is the AALL1331 study, looking at children, adolescents, and young adults. So they took patients aged 1 to 30 years, and this is in the relapse refractory setting. So the overall trial and looked at this is the overall cohort at the top. So the disease-free survival, so significantly better with blinatumomab compared to standard of care chemotherapy. Survival didn't quite reach significance. If you have extramedullary plus bone marrow, also sort of maintained survival probability in terms of disease-free survival, again, not in terms of overall survival. But if you had an isolated extramedullary relapse, blinatumomab didn't seem to be really effective. I'm going to guess probably if you've got tumors more than sort of bone marrow involvement, we know monoclonals struggle to get through to in terms of penetrating the depths of a tumor. So is useful. Again, what's your end game, and really looking to obviously transplant. But really kind of where we're going, well, in the world in terms of what's happening and is blinatumomab first line. We, as I said, started off this talk, we can only wish that this would be our goal and where we can land up. But there are a whole lot of studies looking at blinatumomab in first line. Some of them reported, some of them are still accruing patients. Some are using Philadelphia negative, some Philadelphia positive patients, some in combination with inotuzumab or zigomycin. So they're really kind of looking at there's a whole lot of activity on the go in the first line space. So while we're talking about first line, we have to talk about MRD. So measurable residual disease, I think, is what the world that we've settled on now, not minimal residual disease, because what is minimal, measurable, at least you can sort of define. And there are varying levels, obviously, of measurable residual disease. And we know that MRD positivity is not good, does portend a potential relapse down the line. Obviously, how do we look at MRD? So most of us have been looking at that flow cytometry, so that's multi-parameter flow cytometry, it's MFC, with really good 10 color ones. You can probably get down to the 10 to the -5, but NGS seems to be supplanting this. But really, our ability to access NGS and really picking up the mutations has been, I think, a bit challenging. I'd be very interested to hear the pediatric experience in that. But we certainly, we get a new ALL, we are doing lymphoid NGS up front, but we really are struggling to find markers that we can follow in terms of NGS, and then be able to do the NGS. But certainly that's where the world is moving. And we know that getting CR in ALL is easy. Even in the adult setting, it is relatively easy to achieve. But at least a third of those patients are still going to be MRD positive. And again, the outcomes in terms of survival, if you're MRD positive at the end of induction, is worse. So adults, this is looking at blinatumomab in MRD positive ALL. So this is the BLAST study. Interestingly, if you've looked at the dosing schedule of blinatumomab, the first week, depending if you're active disease or not, is either 9 or 28 micrograms per meter square. This is, sorry, flat rate, flat dose. This is a per meter squared dosing. So this allows for smaller people to be entered, but they do cap at 28 micrograms per day for 28 days. Again, the standard 4 weeks on and 2 weeks off to allow for T cell recovery. We may just say something about T cell exhaustion at the end. I haven't got a slide about that, but certainly that's an issue. And then again, this is patients who are ineligible, went on to 3 more cycles, people who were eligible for transplant. when the donor was available, but were allowed to get 3 more cycles. So this is um, not randomized data, but again, looking at of people who achieve MRD, and really 72% of people did achieve MRD negative status after cycle 1. And again, showing that achieving MRD negativity is a goal in and of itself. Are there randomized studies in MRD positive ALL, at least in adults? Yes, there is. So this is the E1910 study. Now, this study was started prior to the FDA registration of blinatumomab for MRD positive disease after induction chemotherapy. So once that came about, the E1910 did amend their protocol to exclude MRD positive patients. But prior to that, they had randomized people in 2-to-1 fashion, and you can see significantly better outcomes in terms of survival, in terms of even though it wasn't powered for this, I think that it goes kind of follows what I call the rule of thumb. If you can put your thumb between there, that's a clinically meaningful result, and we can take it that certainly this is useful for MRD positive disease in a proven in a randomized fashion. But what about MRD negative? So this is actually really the bulk of E1910 now, where they induced, and then obviously if you're MRD positive in the subsequent lines, you will subsequent time period you will study. But those patients were then given intensification and then randomized to either blinatumomab or standard consolidation. And after that, you're allowed to proceed if you had a donor to allogeneic stem cell transplant. Obviously, they got a whole lot more blinatumomab and chemotherapy. And you can see, again, really overall survival. So this is for MRD negative patients upfront. So you've got induction and intensification, and you now are MRD negative. Do you benefit from the addition of blinatumomab? And the result is most resoundingly a yes. So this is really looking at stratification just up front. So even though this was a study looking at sort of MRD status, and given after induction and intensification, it still can be proven that the addition of blinatumomab was significant. This was presented at ASH in New Orleans in 2022. I remember walking out of it and being blown away, and phoning Amgen virtually immediately going, when are you reducing the cost of your drug so we can all do this? But sadly, that hasn't happened yet. But really, this kind of says, if you've got ALL, you need blinatumomab. And most, you can see the forest plot. I mean, just it's really overall really looking at significance. We are trying to use it a lot more in the elderly. So it's interesting in this study that the elderly didn't benefit as well, but I mean, obviously a whole lot of more studies coming down the pike in terms of use in adult or elderly patients, because certainly that's going to be much better potentially tolerated than chemotherapy, and doesn't really matter kind of whether you transplant or no. And also CD20 status. Obviously, blinatumomab is a CD19 bispecific. Obviously, the big issue has been neurological events. We've actually, I mean, we give around about 1 patient a year blinatumomab. Is kind of what we, in terms of incidence, our prevalence of ALL, and also those people who are on good enough medical aids. So we kind of I've seen a couple, but mostly maybe not up to the 23% of patients. But again, maybe just the small numbers. But certainly more in chemo, where you're giving more intensive chemo, a lot more cytopenias than blinatumomab. Complicated study. So this is now looking at randomized upfront. So this study, the run-in arm has presented the first 10 patients for safety. I'm not going to show that data. This one is still accruing, but essentially they're using in elderly adults blinatumomab with low, so essentially a CVP type of induction, and then cytarabine methotrexate lower doses in the low intensity, and then if you're in CR, and then you just get a second dose of blino. If you're not, you get another induction, second induction course, and then you're randomized to either get blinatumomab or plus low intensity chemotherapy versus a slightly more intensive. Hyper-CVAD in the really elderly is not that easily to get in. So it'd be interesting to see how this data reads out in the end. I think that the standard comparator arm is relatively intensive, but again, maybe that's the point, that we're trying to see, can we de-escalate and keep people alive and treat their disease. So again, this is still accruing. We don't have this result yet, but hopefully, holding thumbs, this will be a positive outcome. This is blinatumomab. So this is a study that was presented at ASH last year and simultaneously published online in the New England Journal, and has subsequently been formally published in February of 2025. And I made the comment to Mark, this is really like these pediatric protocols like blow my mind, but it's pretty easy to follow down that they all got induction, and then if they were sort of, and these are standard risk, but higher and lower relapse risk, and then those higher risks patients were taken down and then essentially randomized to either get blinatumomab versus standard of care. If you had a sort of standard risk, standard relapse, then they looked at again at MRD positivity. If you were MRD positive, then you got randomized to the sort of higher risk arm again. For those continuing on the standard risk, if we couldn't really prove MRD, again, also a subsequent randomization. But if you were in MRD negative, good risk, you got standard chemotherapy. Again, the 15 micrograms per meter squared capped at 28 micrograms per day for 28 days. They did allow downs, but they didn't randomize them according to this protocol. They all got blinatumomab. So again, this is, I think, what if you read some commentaries, put the pediatricians into a real tizzy, really, again, improving on what are really excellent results to start off with. But you can see, just in terms of this is a disease-free survival. So we are nearly achieving, so standard relapse rate, disease-free survival, 97.5%. So almost done and dusted. The ALL is not a problem anymore. For higher relapse risk, so if you're not quite as good, you still gain about 10% compared to non-use of blinatumomab. And this trial was actually stopped early because of the really good results, and there's no excess toxicity in the blino arm. So side effects, actually not terribly much different. I mean, you would think that there would be a lot more seizures and CNS issues in blinatumomab plus chemotherapy, but actually not really at all. So really between the arms and in terms of major side effects, no significantly different outcomes. So essentially really well tolerated, does not confer additional burden in terms of patients, in terms of morbidities. Obviously, apart from cost is the major issue. So moving away just from blinatumomab use in ALL. So mixed phenotype, I know we're calling these things different in terminologies now in WHO 2022 ICC classifications, but most of the literature was still obviously done with the MPAL. But we can see that if you're expressing this is actually before blinatumomab. So what's better? So this is a meta-analysis looking at, do you give them AML or ALL type chemotherapy? And the consensus is that these patients tend to do better with ALL type therapy compared to AML, and sort of hybrid is the worst. And then again, peds always do better in these acute leukes than adults do. But certainly using a pediatric inspired protocol, ALL inspired protocol for sort of mixed phenotype certainly seems to be better. So why not take it one step further? And if you're CD19 positive, use blinatumomab as per ALL. So there really are only at the moment only isolated case reports out there. The largest case series I can find is this one. These guys actually sort of Chinese group presented at ASH last year and have subsequently published, although the publication is predominantly in Chinese. You can get a translation, but only half of it seems to be translated out. So this is from the ASH abstract, and interestingly using blinatumomab plus either venetoclax or and as a cytidine. So actually a very interesting combinations of therapy, and actually very good results. So out of their 6 patients, 4 still in continuous MRD, 1 early relapse. So just go back. So just to say that there are trials, randomized trials running now for MPAL, but obviously they are not going to accrue terribly quickly, because this is quite a rare situation, both in pediatric and adult practice. So if you're going to give blinatumomab, I'm not going to, this is not a lecture on how to give blinatumomab, but you do need to take some precautions. You have to be really au fait with managing CRS and ICANS, and know the staging system and management. Particularly taking temperatures and oxygen saturation, pretty much standard, but and making sure the nurses report them to you, and have tocilizumab available in your pharmacy. It's really criminal to start a bispecific or any cellular therapy, something like a CAR T, without having tocilizumab readily on tap. So that's the anti-IL-6 monoclonal antibody. Interestingly, blino is obviously quite easy, because if you have run into trouble, you really can just stop it, because it's got a short half-life. But I mean, that is also the drug's downfall, as and if you stop unintentionally, then you may actually have to sort of restart, as it were, as from scratch. Most of the ones who've got active disease, so this is really in relapse, standard 9 micrograms for 7 days, but the Golden Gate one for older adults actually starts at 4 days up, they then up escalate to the full dose of blinatumomab. The package insert says if you're giving for MRD positive, you can actually start from 28 micrograms daily from cycle 1, day 1. Obviously, this drug is expensive. and comes in at 35 microgram. It is actually possible to sort of suck that other 7 odd micrograms out and to like leverage it for the next day. I've certainly had some medical aids authorize blinatumomab for 28 days, but give you like something like 24 vials only, and say you must make a plan to try and stretch the drug, because they do know about this. So it's difficult, but it can be done. Obviously, then there comes the whole inpatient admission. So what a lot of us have moved to now is obviously outpatient administration after the initial administration in hospital. So you cycle the first cycle until around about day 10 odd, you really need to do in hospital. But then you need a central venous access device or something that's really kind of stable. There are special lines. You can't just use any line and pump, and you need a way to monitor these patients and obviously have a 24-hour pharmacy available if there are problems. One of the ways to subvert this in terms of whole infusion issues, there are subcut formulation is in trials. Can we mitigate cost by reducing dose? They did find some studies, but not a lot. This is obviously using with chemotherapy, 9 micrograms per day for just date 8 to 14, and then 1 week of 28 micrograms. So that certainly might save costs. So this was a sort of primary induction a study in ALL, giving chemo and then following on by blinatumomab. But there's not a lot of that in the literature. And the other big issue is that obviously that the pediatric dosing is 15 micrograms per meter squared commonly. So if you really have a small child, that becomes quite useful in terms of trying to mitigate cost, and maybe you can end up with 2 vials a day, but it really becomes a problem with the bigger you get. This is interestingly, and you always learn things when you do talks. So I've learned something, because just in terms of our practice, this was actually a survey, some nursing survey of what people were doing in terms of sort of the children's oncology group institutions and how they were managing blinatumomab. So this is outpatient, looking at outpatient administration, and I can see actually about a third of patients needed to come to the emergency room. Just the source of the infusion pumps and where they got them from. And then moving on, we've had a 48-hour cutoff because we believe that that we don't have the bacterial, the preservatives of saline that can allow you to have longer sort of pump times, and our chemo pharmacists have been a bit concerned, but there's certainly a lot out there giving other 4 days or 7 days. So you load the pump with that amount of blinatumomab. That makes it much easier to do cost saving if you can load for longer, because then you can sort of leverage that sort of like 7 micrograms, and once you get to 4 days, that gives you your extra 28 microgram day. So you can certainly, if you're going for a long time, then you can actually leverage that. So that's would certainly be useful for South Africa. And then the other thing I learned was we kind of been very loath about using ports and concerned about sort of bolusing and etc. But in this study, essentially most institutions were using ports as their prime access for administration. And then the problems that happened, so you can see obviously lots things that people might see in hospital, but outside of hospital, line breaks or leaks, clotting, loss of access, resistance. So a lot of fewer, so no problems, as much less in terms of outpatients. You do have more problems trying to give it as an outpatient, but obviously certainly quite beneficial. So doing a talk, just a couple of slides just to balance the books in terms of what else is out there. Obviously to the antibody drug conjugate anatuzumab, anti-CD22, linked to the calicheamycin, so getting the moniker ozogomycin. This was the Innovate 3 in adults in relapse refractory disease. Again, improving outcomes. Does seem to be a bit of an overall survival tale, although again, you really would want to consider going to transplant. Certainly, comparing to standard therapy, anatuzumab, again, significantly better, no matter where you are in terms of all patients up top here, but duration of first remission, where you are in terms of treatment phase, age, and only one kind of not there is the 411, very few patients, and the Philadelphia positivity. So that still needs to be looked at, but everything else really is an issue. The big issue about inotuzumab, because it's again the calicheamycin and has been linked to SOS or VOD, and the higher, if you're going to do a transplant after giving it, if you're giving dual alkylator base, so not using a non-TBI based protocol. And obviously, thiotepa is an alkylator, so I mean, we're using thiotepa as a radiomimetic nowadays. If you can, also again, if you can afford it, but again, dual alkylator, significantly higher rates of SOS, and then you're into the whole defibrotide, which is also not cheap issue. But TBI, small case report series, but no major events. But certainly, VOD is certainly, if you're looking at that, significantly worse for this drug. Interestingly, you actually can give it after transplant. This group gave 19 patients, so predominantly adults, but who had high risk ALL, had been transplanted in further phases, and then did sort of escalating models of inotuzumab. Essentially, really came to a conclusion that actually was very safe to do that. They got to their maximum tolerated planned dose. Obviously, cytopenias, transplanted bone marrows are always a little bit more wonky and susceptible to any sort of disruption. And very good outcomes. I mean, this is in terms of adults in high risk transplants. So this is obviously not a randomized study, but again, very good results in terms of outcomes. Just very briefly comparing the two, obviously complete different mode of action. Administration for inotuzumab much easier compared to the current blinatumomab, where you need continuous infusion for 4 weeks. Both are efficacious. CNS penetration is a sort of a problem and a boon at the same time. If you've got a patient who's got CNS disease, the risk of ICANS is certainly higher, and if you're giving blinatumomab, so then you can consider giving inotuzumab and alternatively finding alternative therapies for the CNS. Obviously, if you've got an isolated CNS relapse, then inotuzumab is not going to be of terribly much use. The risk of VOD and elderly, both are issues, but both can be given. And then just obviously we're out of time, but obviously the world has obviously moved CAR T. We've got a CD19 NK CAR from Immunity Bio in California about to start a trial for relapsed refractory BALL in adults. And then there are other new T-cell engagers from actually, interestingly, both BALL and TALL. So TALL targeting something like CD1A, which is not usually present in normal T cells. So leveraging that some differential CD expression. So just to say, wonderful drugs, but how to get it, who to give it to, it's a real challenge in terms of cost. Again, Aspen's disclaimer slide. Thank you very much.
Thank you, and
Chat box has been very busy. Like I haven't had a chance to. Mark, I hope you've been going through it, but you're okay.
I can't actually see a lot of things, but I've written down a few things. Anyway, we have 6 minutes remaining to the hour.
No, you can carry on as needed.
Okay. All right.
I'm
not sure how long the Zoom link's going to last, but anyway, just to firstly thank Andrew for a wonderfully interesting and very comprehensive overview of this topic. Fascinating how the world is changing at the pace that it is. The first question in the chat actually was from Philippa Ashmore, and I think it's directed to you, Andrew, which says, do you transplant good risk AYA-BALL?
Oh, that's a loaded question. I mean, yeah, considering that anything under over age 10 is, well, I don't know what your cutoff mark is now. And we don't see obviously that, but most of, like, I mean, we're not really, I mean, occasionally we get a younger, like 13 or 14, very occasionally, but I mean, most of our ALLs are 16 and above. Preferably, yes, but we have tried to incorporate MRD and etc. The older we get, the more we are trying to go, but young adults, yes, for sure. But MRD and assessment. But maybe if we have Lino, we could subvert that. But again, that's a loaded topic, difficult answer.
Look, any child for us over 10 would be considered high risk. As far as how you define AYA, well, that's a moving target and has been for many decades. And last time I checked, AYA went as far up as 35 years old. So, so it's quite difficult to pin those down, but we would not routinely transplant a child over 10 unless there was exigent reason to do that based on other risk factors or a lack of remission or cytogenetics that were adverse. And so it would not be an automatic road to transplant. The treatment for children in that category is already intensified as things stand. And so we would follow it's been our practice to follow those normal pathways, and then, as Andrew suggests, to make your decision around transplant based on response. Whether you measure that by morphology and or molecular things is also a controversial question in pediatrics. And Christopher the Mill, certainly in our setting, in the absence of a national treatment protocol for ALL, which of course is the most desired context in which to do that work, and which has been slow to make its way into real space and time. But anyway, that's Christopher the Mill. I see Jacques' question has been managed by a few folks in the chat, so thank you for that.
Just to say that, I mean, you do need, I mean, we haven't really got it in the ALL space yet, but I mean, in the myeloid, we have got a few of the NGSs that we can actually do. Yeah, so we can, it's been answered, depth of sequencing. So you need to tell them you're looking for MRD. You need to tell your lab that's what you want. But yeah, it can be done now. But I'm not certain about in terms of ALL. Don't think we haven't seen that many, because obviously a lot more fusions and things like that in ALL compared to just sort of like DNA mutation. So we see RNA, but I don't know how much whether you guys are routinely doing lymphoid NGS on your ALLs nowadays. I mean, we're starting to, if we get them up front, but I don't know that we've picked up too much yet. Bit of IKZFs and things like that on low levels, which is also, again, how do you interpret that?
Yeah, we've just now actually in this week started to protocolize all of the specifics around molecular testing for ALL and AML, but that's an institutionally specific pathway. The problem hitherto has been that by and large the protocols that have been used have not incorporated MRD in those assessments. Of course, that needs to change. I think the thing that makes that difficult from a pediatric perspective, of course, is that there's not uniformity across the country, certainly not in the public sector, with respect to who is either following BFM or PSYOP or COG, as the case may be. And so that first needs to be consolidated into a single platform. And then, of course, the next difficulty after that is whose MRD we use, what the thresholds are, how those are validated, because all of the centers, as you know, are subserved variously by different labs across the public and private sector. So that will be a very large and very complex discussion, and will be a long process in evolution before we can uniformly look at how we do those things. And of course, using it in the context of a national instrument means that you can collect data and then look at the data nationally, which is really the ideal setting in which to do that, and in which really one should look at the data around, including things like rituximab or Bleno, although you and I both, in the short to medium term, the inclusion of those, even in a national protocol, is unlikely to happen because of cost.
Yeah.
So,
I mean, yeah, I mean, the cost is a major issue. I mean, for those of you not aware, but just in the private sector, one course of Bleno is north of 900,000 rand. So it's, I mean, we had one patient who was authorized for 4 last year, and then in the middle of getting all of this, got CD19 negative progression in her breasts. So not great. So the one patient we did get last year, the previous patient I gave in 2023 was a sort of 18-year-old who was MRD positive at the end of induction. We did, after a long fight, managed to get 1 cycle of blinatumomab for him, and eventually went to transplant. And he's about 18 months out now, and still in remission. So doing well. So, you know, it's sort of swings and roundabouts, but it's a lot of money to pay for even private to say literally one a year, give or take.
Yeah.
Anatuzumab is actually cheaper, but it's we tried to get it for this this patient last year, but there were lots of regulatory import issues. We actually never got hold of the drug. So I know it was a bit of an issue in terms of just getting hold of the drug, let alone getting someone to pay for it.
It also ties into issues like transplant capacity nationally, right? So, you know, we've got 2 beds, and we do reasonably well with 2 beds. So we did 18 transplants in 2023 and 15 last year. So we try and keep those beds full all the time, and that's with help from Critiscare. But again, if you're using Bleno in the context of relapsed ALL as a vehicle to get you to CR pre-transplant, then all of those downstream things impact where or how you can use that. We've had very limited experience with Bleno, so we've used it in 2 patients, both in the relapse setting as a conduit to transplant, both of whom we got to transplant. The one child is now in CR, but with major endocrinopathies post-transplant. And the other patient who had a haplo, unfortunately, got severe pulmonary GVHD and succumbed to that. We also had to interrupt the Bleno in first patient, actually, because she developed neurological problems. So even with a truncated course, we got it into remission pre-transplant. But as I say, 2 swallows do not a summer make. So I'd be interested to know if any of the other pediatric practitioners, there must be many in the room, have used Bleno and what the experience has been. I see a hand up from someone.
Oh dear.
Go ahead.
It's actually my hand, and I didn't mean to. I'm definitely not a pediatric transplanter, although we work with you guys. So I didn't mean to butt in, but you saw my hand. Sorry, let me lower it immediately. But while I now have the floor, so actually it could be a good moment for me to have a little advert for the pediatric transplant group that's working on ALL as one of their first as diseases. And I don't know if Tandeka or Candice are in the meeting today, but I just think there's a lot of impacts in the meeting and other people busy with MRD. So just consider that, as Mark said, we are now trying to build a national type of consensus, and there will probably be a Blino arm and then a other arm. There will be a resource-rich arm and a resource-poor arm, but I think we would definitely want to get a sort of a national consensus. Do you agree, Mark? And I think in that process, we need all hands on board. And as Andrew will know, we don't want to say too much in ALL, Andrew. But you gave an amazing talk as usual. So I really enjoyed it, but the rest of us will be quiet, the adult treaters. So anybody who's interested, you can contact Candice, Hendricks, Tandeka, or you can contact, let one of us as Bloodies A know if you're interested. So that's just from my side, and I would like to know what you think, Mark. You agree? That's important.
Yeah, look, there's no question that using consolidated national treatment approaches for every disease in pediatric cancer improves outcomes. So that's incontrovertible. And so the fact that we are 50 years behind everybody else doing that is an indictment on our community, to be fair. And so it's something that needs urgent attention. And again, that kind of work allows for us to collect data and then to look at, whether we can answer important questions for kids with cancer in this country. So for those two very important reasons, that kind of approach to all pediatric cancer, not ALL, is a necessity. It's really not a nice to have.
We
But
will
anyway,
tag along, Mark. And just one, I have a question actually. In the room, Andrew spoke of 35 as AYA. Is there anybody that would go higher? Do you look at a patient's biological age? How do you guys choose in treating the adult patients?
before we answer that question, Andrew, can I just ask if there are pediatric practitioners in the room who've had any experience with blinatumomab, if they have anything that they want to say or comment on before we take Estelle's question? Any hands? Monica, you want to go ahead?
Yeah, thanks, Mark. I haven't actually been able to use it, Mark, for the very reason that Andrew just alluded to. We've had candidates or patients who would have been reasonable candidates with either MRD or in a relapse setting. But it takes so long for the schemes to actually authorize that you're forced to go in and use a second line salvage therapy. So, it's difficult to actually access it. Just takes too long. It takes too long and you can't afford to be sitting with the kid.
Yeah. Thanks, Monica. Any other comments from the pediatricians in the room? Jenny?
Hi, Mark. It's Jennifer.
Yes.
So we don't have a lot of experience. We've only got one kid at the moment who is tolerating it very well. But yeah, we see it as the next step to transplant. So we're not going to do it if there isn't a donor. Thanks.
Right. Thank you.
I mean, coming back to the story about do we take AYAs to transplant? I mean, also the one thing is we would always upfront for all of our patients look for transplant options. I mean, I think that unless they obviously were not fit for transplant, but if they're fit for transplant, we would look. It all depends on, I guess, on your donor, because again, as we've noted, haplos, I mean, Justin's data in terms of haplo outcomes in ALL wasn't great. I mean, worldwide, haplo is not as an ALL is not doing too badly, but locally, I think I mean, in the haplo study, all the patients really did badly were the ALLs, and a lot more viral infections, and really struggled. And again, maybe with the reduced PTCY dose of sort of between 30 to 40 milligrams per kilogram, times 2 would help. You're not going to see potentially so much basically BK virus and adenovirus reactivation, but our experience has been really dismal with ALLs in haplo. So again, one of those also, don't just look at the disease and the patient, but look at what your transplant option is. If you've got a good donor, we probably would be going for the transplant. Got a bad donor and a kind of a equivocal, do we or don't we do a transplant? We probably would say, hang on, that's the patient not to transplant up front. But of course, then if you relapse, then they're in a worse situation. So it's one of those kind of do we, don't we situations.
Yeah. Well, certainly that's been our experience, that haploidentical transplant is not a free lunch by any stretch of the imagination. We continue to see very complicated GVHD, and our particular struggle is actually with out-of-province patients whose provinces will not fund expensive post-transplant medication like tacrolimus and ruxolitinib. And then what happens is that patients are trapped here for more than a year often, because their GVHD needs to be managed where they can get access to drugs and they can't return home. So they fill up your clinic very quickly. Any other questions or comments that anyone would like to make? All right, so I think all that remains for me is to thank Andrew again for a fantastic talk. I can see from the comments that everyone really enjoyed it. Andrew, thank you for your time, and again for bringing your expertise to bear. And thank you everybody for another very interesting afternoon of the deep dive. And we will see you all again, hopefully in another 2 weeks. Thank you so much.
Thank you.
Thank you,
Yes.
Mark, also, and thanks. It was nice to be with all the pediatricians. So we must
Thank
do
you.
it again.
It's you can join anytime you want, Okay.
Oh, I'll be brave. So no, it was great to talk, Andrew. Have a great afternoon.
Thanks
Thanks,
yourself.
Bye.